What if the cure for the second leading cause of death globally wasn't found in a high-tech fabrication lab or a line of code, but in the evolutionary biology of a predator that has been perfecting its craft for millions of years? Imagine, for a moment, the mechanics of a boa constrictor. It is an engine of pure efficiency. It doesn't just crush, it grips. It utilizes a unidirectional recurved dentition, teeth that angle backward to ensure that once it has hold of its prey, escape is mechanically impossible. Now, juxtapose that terrifying efficiency against the fragility of the human brain during an acute ischemic stroke. We often use the phrase, "time is brain." It's a catchy slogan for public health awareness, but as a physician, I want you to understand the visceral, terrifying physics of that statement. When a clot lodges in a cerebral artery, stopping blood flow, you are losing approximately 2 million neurons every single minute. The brain is effectively suffocating. It is a biological city going dark, block by block, and the resulting damage, paralysis, aphasia, cognitive ruin, is the heavy tax we pay for surviving. Welcome to Dr. Evolution's Toolbox, where I share tools we are using to build a better world with biology. As a disclaimer, nothing I say should be considered medical advice. This information is for educational and entertainment purposes only, and these are my views alone and do not necessarily reflect the views of my employer. Today, we are going to deconstruct a piece of biotechnology that sits right at this intersection of evolutionary violence and life-saving delicacy. We are looking at Emboa Medical and their Thrombus Retrieval Aspiration Platform, or TRAP. They have asked a fundamental question that challenges the orthodoxy of neurointervention. What if we stopped trying to engineer our way out of stroke with industrial mechanics and started biomimicking the perfect grip of a snake? To understand why this is revolutionary, we have to have a sober, intellectual conversation about the current state of stroke care. We are essentially fighting a war on two fronts with weapons that are, frankly, imperfect. For years, the gold standard has been mechanical thrombectomy. We have two main tools in the shed. First, we have the stent retriever. Picture a tiny wire cage on a stick. We shove it past the clot, open the cage, entangle the clot in the metal struts, and pull. It works. It saves lives. But it is violent. Dragging a metal lattice through a delicate cerebral vessel is like dragging a chain-link fence through a hallway covered in wet tissue paper. It causes traction injury. It scrapes the endothelium. In the worst cases, it perforates the vessel, trading an ischemic stroke for a hemorrhagic one. So the industry pivoted to the second tool, aspiration, suction, the vacuum cleaner approach. It is elegant in its simplicity. You snake a catheter up to the clot and turn on the pump. It is generally safer. The data shows significantly lower rates of distal emboli, those little fragments of clot that break off and float downstream to cause smaller strokes and less vessel injury. But here's the physics problem. Aspiration is binary. It works or it doesn't. If the vessel is small or if the clot is hard and calcified, the suction force drops off. The catheter tip gets clogged or it collapses the vessel. This creates a massive clinical gap, particularly in what we call medium vessel occlusions. These account for nearly half of all ischemic strokes. These vessels are too small for aggressive stent retrievers, but too tortuous and delicate for the blunt force of standard large-bore aspiration. This is the Goldilocks zone where current technology fails us, and where patients are left with deficits they shouldn't have to live with. Enter Emboa Medical. They looked at the limitations of suction, the fact that you are relying entirely on negative pressure, and they looked at the limitations of stents, the fact that you are relying on radial outward force that damages the wall, and they synthesized a third way, inspired by the boa constrictor. The hypothesis is fascinatingly simple, but mechanically complex. They posited that a microstructured catheter, designed with an internal topography mimicking the recurved teeth of a snake, could decouple the gripping force from the suction force. Let's visualize the TRAP device. On the outside, it looks like a standard neurovascular catheter, but on the inner diameter of the distal tip, the business end that touches the clot, it is lined with biomimetic structures. These aren't random bumps. They are engineered to emulate that predator's dentition. When the device engages the clot, it uses suction to bring the thrombus in. But unlike a smooth straw where the clot can slip back out if the pressure drops, these microteeth bite into the clot. They provide a mechanical interlock. It allows for a push and pull dynamic. The suction draws the clot in, and the teeth prevent it from sliding out. This creates a combined force factor, aspiration plus mechanical grip, without expanding outward into the vessel wall. It grabs the clot, not the artery. Now, in the world of biotech, a cool idea is nothing without data. We need to look at the numbers, and specifically, we need to look at the worst-case scenarios. It is easy to remove a soft clot from a straight tube. It is hard to remove a tough clot from a curved, narrowing vessel. Emboa tested this in a worst-case neurovascular model using real human blood clots. The results are startling. The trap design demonstrated a greater than 200% increase in blockage removal force compared to a traditional catheter. 200%. In physics, doubling your force without increasing your profile size is akin to alchemy. When compared directly to a conventional smoothbore aspiration catheter, the trap generated almost 3 times the removal force. But force isn't the only metric that matters. First pass effect is the holy grail of stroke surgery. We want the clot out on the first try. Every subsequent attempt increases the risk of vessel damage and extends the time the brain is starving. In these models, standard catheters had a miserable 10% first attempt success rate in difficult scenarios. The trap catheter hit 40%. Even more compelling, when they moved to patient-specific models with real human clots, the trap catheter achieved a 100% removal rate on the first attempt, compared to 70% for the control group. That 30% delta isn't just a number. That is a massive population of patients who walk out of the hospital instead of being wheeled out to a nursing home. So what does this actually mean for the future of medicine? We need to vibe code this technology into the broader landscape of healthcare. We are witnessing a shift from industrial healthcare, which treats the body like a car that needs a mechanic, to biological healthcare, which treats the body like an ecosystem. The trap catheter is a prime example of this. It acknowledges that biological structures, clots, interact with other biological structures, vessels, in complex ways. By using a biomimetic design, we are working with the physics of biology, rather than trying to overpower it. The implications for the patient are profound. If this data holds up, we are talking about dramatically reducing reperfusion times. In stroke, faster reperfusion linearly correlates with functional independence. We are talking about preserving the safety profile of aspiration, low vessel injury, low distal embolization, while achieving the efficacy of the most aggressive stent retrievers. The economic argument is equally strong. Stroke costs the global economy billions in long-term care and rehabilitation. A device that turns a 2-hour procedure with 3 passes into a 20-minute procedure with 1 pass doesn't just save brain cells. It saves hospital resources, reduces length of stay, and gets people back to the workforce. Furthermore, this is a platform technology. If you can engineer a catheter that grips without expanding, you aren't limited to the brain. Think about pulmonary embolisms, clots in the lungs. Think about deep vein thrombosis. The underlying snake tooth microstructure could be adapted for vascular occlusions anywhere in the body. It creates a new category of medical device, the biomechanical hybrid. However, as a scientist, I must pump the brakes. We have to look at the limitations. We cannot let the elegance of the narrative blind us to the rigors of the scientific method. The data we have discussed is largely in vitro. It comes from benchtop models. While they are worst-case models using human clots, a glass or silicone tube is not a human artery. It doesn't spasm. It doesn't have the complex pulsatile flow dynamics of a living hypertensive patient. It doesn't have the inflammatory response of a vessel wall that has been occluded for 4 hours. We also lack the granular clinical trial data, the p-values, the massive sample sizes that define evidence-based medicine. Emboa is still early stage. They are refining the design and establishing differentiation. The valley of death in medtech is the transition from a successful bench test to a successful human trial. The next major milestone is the in vitro porcine models study scheduled for Q1 of 2026. This will be the crucible. Pigs have somewhat similar vascular physiology to humans, but somewhat is doing a lot of heavy lifting there. We need to see if the device navigates the tortuosity of a living animal without causing vasospasm or dissection. We need to validate that the teeth don't inadvertently damage the vessel wall if the catheter is positioned incorrectly. And of course, there is the regulatory pathway. The FDA requires more than just a cool mechanism of action. They require rigorous proof of safety and equivalence to existing devices. This takes time, capital, and patience. But let's step back and look at the horizon. We are standing on the edge of a new era in interventional medicine. For decades, we have been using dumb pipes and metal cages. The Emboa trap represents a move towards intelligence, structural intelligence. It challenges us to look at the natural world not just as a resource to be harvested, but as a library of blueprints to be studied. The boa constrictor evolved its grip over millions of years to take life. It is a supreme irony and a beautiful testament to human ingenuity that we might use that exact same mechanism to save it.